And what a great morning to be at the Carter Center. Good morning. Welcome to our second meeting of the year here at the Carter Center Board of Councilors. I'm Clark Dean, the chair of the board, and I want to welcome all of our online viewers as well as all of you who have gathered today in the day chapel on this beautiful Friday morning. Joining us today from the diplomatic community, as is our custom, I'd like to extend a special welcome to the members of our diplomatic community. And we welcome, if you would please stand, and let's save our applause till the end, Mr. Urs Brenneman, Consul General of Switzerland, Julius Coles, Honorary Consul, Senegal, Mio Maido, Consul General, Japan, Melanie Moltmann, Consul General, Germany, Polly Potter, Honorary Consul, Cyprus. Have I missed any consuls in the room? All right. I'm sorry, I can't see. Please stand up. I can't see your name tag because my eyes aren't great, but welcome so much. Thank you so much. One of the things we love about Atlanta is this is such an international city, and the consulate community really makes a big difference, and we certainly love having that community here at the Carter Center and our Board of Councilors meetings. We also have a couple of other groups that are in attendance today that we'd like to recognize. First, joining us are the Emerging 100, which is the group of Emerging 100 right here. This is part of the 100 Black Men of Atlanta, and my business partner, Marcus Billy, is among them. Welcome. And next, we have a group of accounting and legal interns who are going to be spending their time working with firms here in the Atlanta area. So if you guys would please stand and be recognized. Thank you. We hope you enjoy your time in Atlanta and enjoy your time this morning meeting other community leaders here in this city. And we also have representatives from the Lions Club of Metro Atlanta. If you guys would please stand and be recognized. You know, President Carter always had a special place in his heart for the Lions. The Lions really helped him get to know the whole state when he was campaigning both for governor and president, and it's always wonderful to have you guys here and the extraordinary work that you guys do around the state. I would also like to welcome Dr. Meredith Evans, who's the director of the Jimmy Carter Presidential Library and Museum. And let me add that Dr. Evans, as is our custom, has invited members of this meeting to join us for a complimentary tour of the museum after the meeting today. Again, if you haven't been, you really, really, really should go. It is an extraordinary exhibit. I think I'd mentioned at the last meeting, my wife actually brought a group of students from Galloway here a couple of months ago. And not only were they astonished, she was astonished. I was like, you know, honey, is this like the first time you've been to this thing? It's been in town for a long time. So don't be ashamed if you haven't gone, but go because it's really cool. So thank you, Dr. Evans, for all you do to bring that story to life. We appreciate it. It's also my pleasure to welcome the Carter Center leadership who have joined us here today. We have Matthew DeGallen, Vice President of Communications, who you may be seeing due to a pending award that might be on its way this weekend, so be on the lookout for that. Dr. Kashef Ijaz, Vice President of Health Programs. And of course, our fearless leader, Board of Trustees of the Carter Center, Jason Carter. Now, after our meeting today, we'd like to welcome everyone to rejoin and reconvene for more coffee and fellowship after the meeting for as long as you guys would like. But make sure you take a tour if you haven't, because that's fantastic. As a reminder, we have 2 more meetings this year, which is going by very fast. The next meeting is on September 19th, and then the last meeting of the year is December 12th. The September 9th meeting is our annual meeting, so it's a big one, so make sure to underscore that on your calendar in September. It should be a great program with a lot of great content. So we hope everyone can join us for that. And now, on with our program. First, we'll hear from Dr. Rana Shab. Associate Director of Conflict Resolution Program, who will discuss supporting inclusive and sustainable peace in Syria. Next, we'll hear from Sarah Phillips, Associate Director of Public Policy of the Mental Health Program, who will highlight Advancing Mental Health Equity, the Georgia Parity Awareness Campaign. And finally, Dr. Greg Nolan, Director of River Blindness, Lymphatic Filariasis, and Schistosomiasis and Malaria Program, will present on expanding support for river blindness and lymphatic filariasis in Africa. After these presentations, we'll hear from Jason Carter, Chair of the Board of Trustees, who will make remarks and take questions, which I'll be thinking of your questions during the meeting. We want to make sure that we have a lively discussion. Dr. Rana Shab is the Associate Director of Middle East and for Data and Analysis in the Carter Center's Conflict Resolution Program. She earned a bachelor's degree in Quantitative Economics and International Relations from Tufts University, a master's in Foreign Service from Georgetown University, and a doctorate in International Affairs from the Georgia Institute of Technology's Sam Nunn School of International Affairs. Dr. Shab previously worked on U.S. policy towards the Middle East in Washington, D.C. Internationally, she has worked with the Carter Center designing, fundraising, managing, and implementing peace-promoting projects in Israel, Palestine, Lebanon, and Syria. She worked with the UN and a rural NGO in Lebanon to help build community resilience and promote sustainable livelihoods by removing incentives that often lead to violent conflict. So thank you, Dr. Shab.
Thank you. Good morning, everybody. It's such an honor to be here with you today and to share really some of the joys and the impact of the Carter Center's work in Syria in such a difficult region. I think it's important to take note that even just yesterday, with the events happening in the region, we are working on shifting tectonic plates. So we are constantly assessing and reassessing how the Carter Center can be impactful in such a fluid and dynamic environment. So I just wanted to point out that we are not oblivious to the fact that we are dealing with such difficult currents, and we strive for the most impactful way to make a difference in the current crossroads that we are at. But for today, we are focusing on the Carter Center's work on Syria. Syria is at a crossroads. For those of you who have not been following closely, Syria is undergoing a critical juncture in its history, an opportunity that nobody saw coming. Just 6 months ago, a decades-old brutal regime collapsed, laying the foundation for a new page, a new beginning, a new Syria. Now, the current authorities leading Syria are a group named Hayat Tahrir al-Sham, HTS for short, a group derived from Al-Qaeda, a designated terrorist group. So all this to say that yes, there is a new beginning, but the road ahead is not easy. The Carter Center has been quick to act and to get in and to seize this important opportunity. A colleague and I just returned from Damascus a couple weeks ago, and I'll share with you some of those findings. But I think it's important to take a breath and step back and acknowledge that the Carter Center is able to be so agile and to pivot in such moments because we are standing on the shoulders of giants. President Carter and Mrs. Carter were involved in and around Syria for decades and visited Damascus many, many times after leaving the White House. And even before the Civil War, and even before the Arab Spring in 2011, the Carter Center and President Carter were engaged in dealing with world leaders and regional leaders and Syrian leaders to try and find sustainable and harmonious paths forward for the diverse community that lives in the Middle East. So what I wanted to share with you here today is a painting that hangs in front of the Cypress Room, if you're familiar with the Carter Center, painted by President Jimmy Carter himself. And this painting depicts an ancient street in Damascus where the Apostle Paul took refuge for a few days after reaching Damascus. And so I was told a few days ago that this is President Jimmy Carter's favorite spot in Damascus. Fast forward over a decade later, my colleague and I had the opportunity to walk these streets and to meet with people who remember President Carter very fondly. So, in the simple lyrics of a country song, we were country when country wasn't cool, meaning that the President Carter and the Carter Center cared and stuck with the causes that were difficult and that the world ignored. And so, building on those shoulders, again, a colleague and I had the privilege and the honor to cross the border from Beirut, Lebanon, into Damascus, Syria, and to engage with many interlocutors asking, how can the Carter Center be the most helpful at this critical juncture? And we were greeted with the biggest smiles from ear to ear, including from the bearded security guards and Border Patrol, and the groups that we met with in Damascus. We met with old people and young people who had never left Damascus, even through the decades-old brutal civil war, university students that were planning their future and their dreams and their future livelihoods, civil society activists, and religious leaders. And the most common thread in all the conversations was that the work of the Carter Center is recognized, respected, and loved. Recognized, respected, and loved. And as an individual, me, a little person working for the Carter Center, was so humbling to feel like I'm part of a bigger family, a Carter Center family, the Carter Center mission, which is to wage peace, fight disease, and build hope, a mission that resonates with every human around the globe. So I wish to bring that feeling back because it's almost indescribable. We happen to be in Damascus at another critical juncture in history, where President Donald Trump was giving a speech in Riyadh, Saudi Arabia, and he announced the lifting of sanctions against Syria. Now, Syria, in modern history, is one of the most heavily sanctioned places in the world, isolating it economically, politically from the rest of the world. So my colleague and I found ourselves in the Umayyad Square, a major gathering space in Damascus, and witnessed firsthand major jubilation, celebratory gunfire, hugs and kisses in the street, with hope running high that with the lifting of sanctions, there is a new beginning for Syria. Now, witnessing this firsthand was very emotional because it shows to the optimism that lies ahead, but it also underlines all the work that needs to be done. With this happiness and jubilation, the Syrian population now has high expectations. The dictatorship has fallen. Sanctions have been lifted. And so, is life getting better for Syrians? And actually, the situation on the ground has not improved to the degree that expectations are running high. And so with this disconnect between expectations and conditions on the ground still being wrought economically from a security perspective, there is a major risk of Syria falling back into that civil war that it just came out of. And so this is the crux of the issue that the Carter Center's work is trying to address. If there is no immediate peace dividends for the Syrian people, then the road ahead and forging the path for inclusive and sustainable peace is at risk. And the way we do this at the Carter Center and the Syria team is in three ways. The first way we do this is by maintaining our position as a thought leader when it comes to thinking about solutions to ending the Syrian conflict. The Carter Center has been researching and publishing on this issue long before the world woke up 6 months ago and gave more attention to Syria. And the areas that the Carter Center focuses on are those crucial areas that the rest of the world is neglecting. So this is advanced research on the effect of sanctions on the Syrian people, on the humanitarian sector, on the education sector, and how can sanctions be leveraged in order to bring about a diplomatic solution. All of this to say is that this work and this finding is shared with US policymakers, European policymakers, and when we were just in Damascus, we were told that this public library of the Carter Center has been translated and shared with the new authorities in order to help them make the best decision possible to reduce the suffering of the Syrian people. Now, building on that thought leadership and the importance of the relationships that were begun ages ago with President and Mrs. Carter and that sustained engagement and nurturing of relationships, the Carter Center is uniquely positioned to bring differing Syrian voices that typically do not agree around the table to forge a common way forward. And the most effective way to do this, we have found, is to focus on technical issues that bring about real change to the Syrian people, yet that have a political cover. So it's easy to come to the table and talk about these issues. And this approach is deeply rooted in President Carter quoting his own school teacher that used to say, "In unchanging times, we must hold to those unchanging principles." So in this transition, what are those unchanging principles that the Syrian people, the international community can hold to in order to help guide the transition? And one of those key areas that we have been working on, there are many, has been advancing access to education in Syria, because this is a topic that everyone agrees is of paramount importance. Now, finally, another way that the Carter Center has been impactful over the years and today particularly is that the Carter Center has the oldest and most granular data set on the Syrian conflict. The Carter Center has been tracking this conflict since its onset, year in, year out. And when the world woke up 6 months ago, asking questions, what's happening, who controls what in Syria, the world and a dozen media outlets turned to the Carter Center asking for our data to help explain the conflict to the general public. And so you see here the Carter Center's data set featured in the New York Times explaining to the general public who controlled what part of the territory at what point in time. And so this is one way that the Carter Center's research and data collection helps inform the general public. We worked on this over a decade ago. We are still working on it today. And every month we send out an updated map on who controls what part of the territory to decision makers, diplomats, humanitarians, in order to advance peace building and humanitarian causes. So this data is widely shared for those who want to use it well. Finally, this data set has provided us a real opportunity to be innovators at the cusp of data analysis, artificial intelligence, and peace building. The data set that we have tells you basically, and I'll break it down, that there was an airstrike in this village on this day. And if you happen to know that information, you also know that this weapon fails to detonate at a certain rate. So, if you have the information that we have, the Carter Center developed this innovative methodology to predict where unexploded ordnance lie across Syria, and that's UXO for short. So these are Carter Center maps that show that over 1 million explosive munitions were used in the Syrian civil war and shows the concentration of the conflict over time. Now, this interactive map takes that data and shows us where unexploded ordnance lie across Syria. And this is crucial information because in order for a farmer to access his fields or to access schools, agricultural lands must be cleared from the danger that is unexploded ordnance. And so, again, using this innovative methodology to help deminers understand where to prioritize, the Carter Center very generously shares these maps with humanitarian actors to help them prioritize their work and make the best decision possible. And in the spirit of continuous improvement, we have partnered with tech companies to see how we can integrate artificial intelligence to more quickly classify our data events and categories that basically help us predict or estimate where unexploded ordnance lie across Syria. And so finally, using our thought leadership, our ability to convene parties that typically do not like to meet, and our cutting-edge data and analysis capabilities and marrying that with artificial intelligence, the Carter Center's work directly works to impact those peace dividends that we are trying to launch in order to set Syria on a sustainable path for early recovery, reconstruction, peace, and prosperity. And with that, I want to thank you so extremely much for your attention and for being part of the Carter Center family. Thank you so much.
Thank you, Dr. Shabwith, for your incredible work in such a complicated and difficult region of the world. Really, really appreciate it. And I realized that I was remiss. One of the things we do here at the Carter Center, we make a lot of recognitions, and usually by this point in the program, everyone would have stood up and been recognized, and I realized that a lot of you haven't been. So if you are a member of the Board of Councilors, if you would please stand and be recognized. So thank you for being here with us today. And our members have brought a number of guests who we're excited for you to be joining today. And if our guests would please rise and be recognized. And then we have the great staff who actually makes this program possible. If you guys could please rise and be recognized. There we go, come on. Outstanding. All right, so if anybody hasn't stood up to be recognized, let me raise your hand. Okay, we're good, we're good. Outstanding. On with the program, on with the program. Sarah Phillips brings a background in legislative relations, policy strategy and analysis, and coalition building in her role with the mental health program, where she leads a team of advancing behavioral health parity, payment for youth mental health services, mental health for older adults, and decriminalization of mental illness and substance abuse disorders. Previously, she served as the Director of Policy Strategies at the Georgia Health Initiative, monitoring the policy environment to design and implement strategies to promote health equity in Georgia. As a senior manager of the policy and advocacy at Georgia Watch, Phillips identified the needs and disparate impacts affecting historically marginalized populations and guided the development and implementation of equitable policies to combat these disparities. In addition, she worked at the Georgia State Capitol conducting policy research and legislative analysis. Sarah graduated with honors from Georgia State University with a bachelor's degree in political science and public policy and a master's degree in public administration with a concentration in policy analysis and program evaluation. So now we welcome Sarah. Thank you.
Good morning. So great to be here. Thank you for the lovely introduction, and it's a true privilege to join you all this morning and join my colleagues, Dr. Nolan and Dr. Robb, in presenting about our work. It is a lovely Friday morning to be at the Carter Center, so thanks all for being here. My name is Sarah Phillips. I am a legislative strategist and an advocate and a policy analyst and a lobbyist by training, but here at the Carter Center, I am the Associate Director for Public Policy with the Mental Health Program. True privilege to be here today with you and talk about the work that we're doing to advance equitable access to mental health care, particularly through the enforcement of behavioral health parity laws, and to share the story of our Georgia Mental Health Parity Campaign. So to start, a little bit about what we do on our public policy team in the mental health program. We work to improve mental health systems through evidence-based policy. We're continuously expanding our footprint, both here in Georgia, into other states, and building out and maintaining a federal presence in Washington, D.C. We monitor how parity laws are implemented and enforced, advocate for school-based behavioral health and payment for youth mental health services, and support older adults with serious mental illness and systems of care. We also bring together stakeholders, including advocates, providers, policymakers, and the media at our annual Rosalynn Carter Georgia Mental Health Forum to advance dialogue on salient mental health policy issues across the state. And I would also be remiss in saying, if I didn't add that next year is our 30th anniversary of the Rosalynn Carter Georgia Mental Health Forum, so I hope that you all will join us. So a little bit of table setting. What is parity? As I mentioned, one of our top priorities within the mental health program public policy team is mental health parity. This is a cause that Mrs. Carter championed for decades, going all the way back to her time in the Georgia governor's mansion. I sometimes like to say that parity is not necessarily what many of us would consider the glamorous, flashy public policy work, but it is so important, and it is so critical to everything underlying access to care. So I'm always delighted to share more about it with groups like this. So in simple terms, parity means that insurance must cover mental health and substance use disorder care on equal footing with physical health care. That means no higher copays, no arbitrary visit limits or limits per year, and no unjustified denials of care for behavioral health as it compares to your physical health, your medical and surgical care. This can often feel a little esoteric, difficult to understand, and we can get into technical topics like non-quantitative treatment limitations and things like that, but ultimately what matters is the effect that it has on people and on communities and their access to care. So I find it easier to understand parity through that lens. Without parity, people are often forced to go out of network, pay more for their care out of pocket, or are denied coverage altogether. They may not receive preventative care that would save themselves or their families from reaching the point of a crisis, or they may be forced to navigate a very confusing insurance system while they're amidst a crisis. And of course, these barriers disproportionately impact underserved communities and contribute to worsening health outcomes altogether. So the bipartisan Paul Wellstone and Pete Dominici Mental Health Parity and Addiction Equity Act of 2008, it's quite a mouthful. You'll more often hear it referred to as MAPIA. This was signed into law in 2008, establishing that behavioral health conditions should be covered at parity with other illnesses. A few years later, the Affordable Care Act's essential health benefits expanded the number of plans that must offer behavioral health coverage and comply with parity. But federal laws alone are not enough. One of those reasons being insurance is regulated and administered at the state level. So state laws are essential to ensure that these protections are actually implemented and enforced. That is why Georgia's Mental Health Parity Act of 2022, House Bill 1013, was such a milestone here in Georgia. It was a bipartisan effort. It was championed by the late Speaker David Ralston, and it gave Georgia the tools to hold insurers accountable for providing equitable mental health coverage. So I often like to say, as hard as it is to pass a law, implementing a law is much harder. And this is why we at the Carter Center continue to monitor and advocate for parity and its most effective implementation, even though we're about 3 years since the law officially passed. So here in the state of Georgia, we have two state agencies, the Department of Community Health and the Department of Insurance. Department of Community Health oversees public insurance such as Medicaid, State Health Benefit Plan, Peach Care for Kids, and of course Department of Insurance oversees our private insurers in the state, such as those that are self-pay or employer-sponsored. So these two state agencies are responsible for monitoring parity compliance per the law, and they also must take action and hold insurers accountable when parity violations occur. So as such, we are monitoring the agencies as they're implementing the law. They're still very much in the infancy of this implementation process and how they respond when violations occur. We work closely with both DCH and DOI, offering technical assistance and sharing insights from the community as we have a line of sight into a lot of that information and on-the-ground experience that many of the state agencies are often not privy to. Policy change, of course, is incremental and iterative, so we continue to engage with legislators and advocate for even stronger parity laws. One example of this, this past 2025 Georgia legislative session, we supported House Bill 612, which would strengthen enforcement mechanisms for parity. We also hold an annual Parity Day at the Capitol each legislative session and lead the Georgia Parity Collaborative, a coalition of more than 70 organizations, both state and national, who are committed to advancing parity. And we educate consumers about their rights because many people don't even know what parity is, let alone that they have the right to take action if they feel that they have experienced a parity violation. Some state parity laws have a public awareness campaign built into their legislation. One of those states is Illinois, for example, where their Department of Insurance is not only responsible for monitoring insurers and enforcement activities, but they also have a responsibility to their state's consumers to ensure that people understand their rights and help them navigate when they have been denied coverage for care that they're entitled to. But notably, the Georgia legislation does not have that clause within the law, so the Carter Center has stepped in. In 2023, with the generous support of the Arthur M. Blank Family Foundation, we launched our first Georgia Mental Health Parity Awareness campaign in Savannah and Albany. These cities were identified due to their high BIPOC populations and Medicaid enrollment. Additionally, the campaign had a special focus on women who are often serving as the healthcare decision makers in their households. To start, we conducted a focus group with our fellow advocacy organizations representing various communities to gather feedback on messaging that would resonate with the communities we're serving and be most effective. Campaign materials could be found in a variety of places and spaces, including on billboards, as you see here, print ads in local newspapers, branded content articles, social media ads, digital display ads on the web, radio ads, and targeted email campaigns, all leading back to our campaign website, which is georgiamentalhealth.com. Our website provides information about parity, what a parity violation might look like, and how to take action if you have been denied coverage. And we also held in-person community roundtables in both Savannah and Albany to talk about parity with key stakeholders, as well as conducted pre- and post-campaign surveys to assess our campaign's impact. Here you can see more examples of the ways in which our creative concept was used to drive people to georgiamentalhealth.com for more information. And another thing to note is that we produce certain resources as well as our campaign website in Spanish too. So the results were powerful. 2 in 5 community members reported seeing or hearing about the campaign. Nearly half of the communities noticed an increase in information about mental health coverage over the past 2 months, which is when the campaign had been active. 33% of respondents said that they did not need this type of care at the time of being surveyed, but would seek it out if they did. So this was an increase from 26% pre-campaign, 26% to 33% to be clear. But perhaps most strikingly, the percentage of people worried that insurance wouldn't cover mental health care dropped from 30 to 13%. I'll say that again because that's the data that gets me really excited about the impact. People worried that insurance wouldn't cover mental health care dropped from 30 to 13%. That is a huge shift in perception and a sign that awareness can truly empower people. Seeing the success of this first campaign iteration and knowing that further efforts are needed to raise awareness, we knew that we wanted to continue this effort and develop a second campaign iteration right here in Atlanta. So to ensure that the campaign truly resonates with our target audience, who we identified as Black women ages 18 through 44, we conducted focus groups. Interviews took place with community leaders, who are experts in mental health or women's health concerns for both Black women in Atlanta through lived experience, professional experience, or both. And their feedback was clear. Use bold colors and Afrocentric visuals that catch the eye, show relatable imagery of Black women like natural hair and friendly expressions, keep language simple and hopeful, and include Atlanta-specific references to promote authenticity. So with these recommendations, we created our second iteration of the Georgia Mental Health Parity Awareness Campaign. You'll notice it's a very different look and feel from our first campaign, but still the same message that your body and mind are equally covered. The campaign launched on May 1st and will run until July 20th, so it's currently active. The campaign materials and information are applicable to everyone, of course, throughout the state of Georgia, but like I said, we identified Black women between the ages of 18 and 44. Research has shown that they're less likely to seek care due to previous poor experiences with the healthcare system, high cost of treatment, and perceptions of stigma for having a mental illness. This campaign, once again, is intended to meet people where they are. We've placed ads in doctors' offices and pharmacies, bus shelters, on billboards and digital displays, and in various places around the web and on the airwaves. So you can see them driving around Atlanta right now as we speak. We're also really excited to unveil a mural in Atlanta's Castleberry Hill neighborhood, partnering with a local artist and the Atlanta Mayor's office to extend and amplify the campaign even further. And that mural will be on that wall for at least 5 years, so it's a really nice extension of the life of this campaign. And the mural will have a community launch event with engagement opportunities in late July or early August. Here are more examples of our creatives that can be found around town and on the web. We've also created a partner toolkit to help organizations share campaign materials. It includes social media templates, email text, and downloadable graphics. We're gathering feedback right now about how useful this partner toolkit was so that we can make it even more effective for grassroots outreach. We've also gained some really great media traction around the campaign and parity awareness. We've been featured in the Atlanta Voice, in the Atlanta Journal-Constitution, on WSB Radio, among other platforms. We're also spotlighted recently in the AJC's Atlanta America's Black Mecca series, and a story focused on mental health for Black Atlantans. Now, looking ahead at continued efforts, of course, this Atlanta campaign, like I said, is still live, so we'll continue to promote it and evaluate the impact and reach, particularly for our target audience, but as well for all Georgians. We'll share our findings with our state agencies, Department of Insurance and Department of Community Health, and use them to inform future efforts. We're also exploring expansion to other communities and even other states. Montana, for example, has expressed a great deal of interest in adapting our public awareness model. And of course, we will advocate in every way we can across multiple states for improved parity laws and their compliance and enforcement so that every person who needs care for their mental health is able to access it. Finally, I would be remiss if I didn't also mention that the success of the campaign would not have been possible without the incredible collaboration of our wonderful Carter Center communications team, who have lent their time and their expertise to ensure that this campaign is effective and impactful. Because I know policy, I don't know comms, so their collaboration has just been huge in the success of the campaign and our ongoing amplification and messaging. We're so proud of the work that we've done so far and are eager to see the continued efforts and impact that we will make by empowering people with the information that they need to get affordable, quality, accessible behavioral health services and supports. Thank you so much for allowing me the opportunity to share about our work with you this morning, and I look forward to taking questions after Dr. Nolan.
Thanks, Sarah, and thank you for your work in meeting people where they are. I think a lot of these things, and especially healthcare, starts with trust, and a lot of times there's not a lot of trust in our communities, and this work is really restoring that trust. So thank you for all that you are doing. And next, we have Dr. Greg Nolan. Dr. Greg Nolan joined the Carter Center in 2011 as a program epidemiologist with more than a decade of basic and applied research experience in parasitic diseases. Then, in June of 2020, Dr. Nolan was named as the director of the Carter Center's river blindness, lymphatic filariasis, schistosomiasis, and malaria programs. He earned his Bachelor's of Science from Davidson College, a Master in Public Health in Global Epidemiology from Emory University's Rollins School of Public Health, and a doctorate in Molecular Microbiology and Immunology from the Johns Hopkins University's Bloomberg School of Public Health. Prior to joining the center, he was a postdoctorate fellow for the University of Minnesota's Malaria Research Program in Kisumu, Kenya, in partnership with Kenya Medical Research Institute. He began his career as a guest researcher for 3 years at the U.S. Centers for Disease Control and Prevention. Dr. Nolan currently holds an adjunct professor positions in the departments of epidemiology and Hubert Department of Global Health at Emory-Rollins School of Public Health, which is a mouthful, but actually a very prestigious and important program. So, Dr. Nolan.
Thank you, Clark, and congratulations on that mouthful of diseases. Those are complicated words. So, good morning, everyone. Yeah, there are so many negative news headlines that circulate in our current times, and it's so important for us to tell these positive stories. So my colleagues and I were just thrilled to be able to share some good news stories with you this morning. I'm going to talk specifically about the Carter Center's efforts to expand support for river blindness and lymphatic filariasis elimination in Africa. So what are these two diseases? Onchocerciasis, also called river blindness, is a parasitic infection. It can cause both skin disease and blindness that are a result of inflammation and damage caused by microscopic worm parasites that move throughout the body and even can pass through the eye. It is spread by small biting black flies that breed along the banks of rapidly flowing rivers. And so for that reason, there's a geographic proximity association with rivers, and thus the name river blindness. Lymphatic filariasis, also called elephantiasis, is caused by a related parasite. This parasite has a preference for living within the lymphatic system, and it can cause chronic dysfunction to that system, which can result over time in chronic accumulation of fluids in the extremities, particularly the legs and feet and even arms. And so over time, in severe cases, you can have legs such as this leg shown on screen, which can resemble an elephant, and so again, thus giving rise to the name of this infection. So while neither of these diseases is overtly fatal, you can imagine the life-altering effects, especially in rural traditional societies where many people, if you approach a market with a leg that might look like this, not only do you have difficulty perhaps even just finding footwear, but you can imagine that people might stigmatize you, isolate you from the community. Even young children can suffer the effects of these diseases, may have difficulty finding a marriage partner. And so you can understand both the social, the financial, and mental health consequences that these diseases can lead to for affected individuals. Globally, up to 240 million are estimated to be at risk for river blindness. As shown on this map here, basically any country that's colored is at one time endemic for river blindness. So there are 6 countries in the Americas region that are endemic for this disease, but really 99% of the burden is concentrated in Africa. Similarly, there is an even larger proportion of the global population at risk for lymphatic filariasis. This is because not only does this disease occur in selected countries in the Americas, a vast burden in Africa, but also in highly populated regions in Asia. But there, within Africa, for lymphatic filariasis, there are an estimated 400 million people at risk for this disease alone. So let me take a step backwards in time for a moment. About 20 years ago, in 2002, in fact, even in this very room, a panel of experts gathered to determine whether it was possible to eradicate onchocerciasis, river blindness. By that means to stop transmission and to wipe this disease out from across the planet. And at that time, the conference came to the conclusion that, in fact, this was an impossible goal, that based on the tools that were available at that time, that eradication of river blindness was, in fact, not possible due to the tools that we had and just simply the high burden of infection on the African continent. But ever the optimist, President Carter says that shouldn't stop us from trying, and specifically trying to do what we can with the tools that we have. And so specifically, he said that there's no need for people to suffer when we have simple prevention strategies. And so what are those prevention strategies? Well, there's a miracle drug. It doesn't happen too often in science, but yes, vaccines are miracles. Yes, this drug, ivermectin, is a miracle for these parasitic infections. And so the drug ivermectin kills the microscopic larvae of these parasites in the body and can eventually break the transmission cycle to flies when given on a once or twice per year basis to all at-risk individuals in a community over a period of time, even up to 10 to 15 years, which is the lifespan of the adult worms within the body. In 1987, the drug company Merck made a monumental decision to donate this drug free of charge, as much as needed for as long as needed for the elimination of river blindness. A few years later, GSK also donated the drug albendazole, which is used in combination with ivermectin, for the elimination of lymphatic filariasis. And so thus, the global community launched first a control and then eventually an elimination program for these diseases across the world. And so early on, President Carter became really an advocate in chief for letting countries know that these medicines were available free of charge. And so this is a picture with of President and Mrs. Carter with Dr. Roy Vagelos, the CEO of Merck, who made that decision in the late 80s to donate these drugs. This is a site visit in Chad, I believe was taken in 1994. So in 1996, the Carter Center officially launched our program to control and eliminate river blindness, lymphatic filariasis. Over the course of that time, we have assisted with the distribution of more than 600 million treatments for river blindness and an additional 200 million treatments for lymphatic filariasis. In 2002, we surpassed a milestone of having assisted with the distribution of 500 million treatments, and so we commemorated that with this lapel pin, which our Ethiopia program colleagues designed for us. There's lots of symbolic imagery in there, and I'd be happy to share some of those details with you, but I'm wearing this lapel pin, and we've circulated that amongst our staff and colleagues to just celebrate that accomplishment. But really more important than treatments distributed is treatments stopped. And so for lymphatic filariasis, across our entire populations at risk, with a concerted effort of decades of investment, more than 32 million people now no longer need treatment for river blindness. That's approximately 55% of the total populations at risk for this disease. Even more impressively, for lymphatic filariasis, now 36 million people in communities where the Carter Center serves no longer need treatment for lymphatic filariasis, and that's 95% of the original population at risk. So these are incredible achievements. These are hard-earned achievements over decades of investment, and of course, just accomplishments and celebrations, a testament to our partnerships with ministries of health, with communities, with other partners. As a result of these treatments stopped, 4 countries in the Americas, namely Colombia, Ecuador, Mexico, Guatemala, have achieved WHO verification of having eliminated river blindness. Up until a few months ago, I used to say that these were the first and only countries that have achieved this status. I'm very happy to say that now the first country in Africa, Niger, has also achieved this status. So what we have seen is an accumulation of positive results in the Americas region that we are then now applying to the African context, where that force of transmission is so much more intense. So these are the early wins in the Americas, and we are working towards and looking forward to those future and very proximate celebrations in Africa. So in the Americas, only 6% of the original at-risk population is still in need of transmission. That's amongst a very small indigenous population, the Yanomami area, that live on the cross-border region between Brazil and Venezuela, deep in the Amazon jungle. Again, thinking about what are some of the early wins in Africa, I want to feature Uganda, where Carter Center began working since the very beginning, the launch of our program in the late 90s. In Uganda, where there were 17 originally endemic foci, 16 of those foci have now stopped treatment for river blindness. And so, across the map you can see all of these foci, the colored areas. They were once red. They are now green. So the main message for any, at least of our health program maps, is green is good, red is bad, and you can see that in Uganda, the map is almost entirely green. They will hold their next committee meeting in August of this year, and we predict that they will make a determination that the 17th and final foci may have met criteria to stop treatment for river blindness in Uganda. That would be a momentous achievement for Uganda. Uganda would join Niger and also Senegal. I believe I heard we have one of our representatives from Senegal with us here this morning, as the 3 countries in Africa that have so far qualified to stop treatment for this disease. So, kind of what does this groundswell of enthusiasm, the successes in the Americas and now the emerging success in Africa, where's the positionality within the global community for this? So we are thrilled to tell that in late 2023, a consortium of donors, namely the Gates Foundation, the government of UAE, and a number of other international partners, came together to announce the formation and expansion of a project called the Reaching the Last Mile Fund that will donate at least $500 million towards the goal of eliminating both river blindness and lymphatic filariasis in Africa. So it's a tiny picture, but you can see our fearless CEO there up on stage as part of this event. I know Jason was also in Dubai at that time for a number of guinea worm celebrations. And so this was a momentous event, at least for our community in these diseases, really consolidating the support from the donor community towards the elimination goal. So the Carter Center has been asked to serve as one of 3 implementing partners for this project. And so we have the opportunity to expand our support from 4 legacy countries in Africa, namely Nigeria, Sudan, Uganda, and Ethiopia. Uganda down there. It's hard from this angle to see exactly. To expand our support from those 4 legacy countries into 5 new countries, those countries shown in orange on this map, namely Angola, Burundi, Chad, Madagascar, and South Sudan. And so this is a momentous event for our program. For the past 30 years, we've been focused on the Americas and these 4 countries in Africa, and this is now the opportunity for us to continue to expand and grow. So let me conclude really just by saying, I may have said it in this forum before, but as I reflect even just 20 years ago, the global community thought that this was an impossible goal. This really reminds me of one of my favorite quotes from Walt Disney that said, "It's kind of fun to do the impossible." And so with your support, the support of donors, partners, and our ministries of health and others, and I do especially want to also acknowledge the Lions Club international groups. You all have been with us from the beginning of this program. You all owe a vast amount of credit, so we certainly thank you and everyone else in this room for your support. So with that, let me stop and say thank you very much.
Thanks, Dr. Nolan. Thanks for everything you're doing to help the Carter Center do the impossible. Those things are worth doing, and just the pictures, the pain and suffering that's prevented by that kind of care. Many of you might have actually been in the room. Every year there's an annual Bill Foege Global Health Awards celebration. President Carter was a recipient of that award a couple of years ago, and this year Merck was actually given one of those awards for its contribution in providing ivermectin in this project. So this is incredible work, and thank you for what you're doing. And now, for remarks and questions, I'm pleased to introduce my friend and the chair of trustees for the Carter Center, Jason Carter. Jason is a partner with the law firm of Bondurant, Mixon, and Elmore. He served in the Georgia State Senate. He is a trustee of the Georgia Bar Association. Like several others in the room, he is a returned Peace Corps volunteer, having served in South Africa. He is a former Carter Center intern, and he is the first grandchild of Jimmy and Rosalynn Carter. Jason.
Thank you all very much, and let me thank in particular the members of the board who brought visitors today. I mean, one of the important things about this group is we're trying to let people know what we're doing, and I think Carolyn Donnelly gets the award for the most visitors, and so we appreciate all of you guys for being here. You've heard good news about the Middle East. You've even heard us say good things about pharmaceutical companies. You have watched an enormous display of bipartisan support for dealing with mental health, right? I mean, these, as Greg said, there are good news stories out there, and I just am really honored to today have had you guys display the breadth of what the Carter Center is working on and the innovation that's associated with it. If you can eliminate river blindness in Uganda, you can eliminate it anywhere. And I think that is something that when you look at the Carter Center's partnerships across the world, and this is true both in each of these presentations, but to use river blindness as an example, really proving out the concept of how we can get this done. As he said, it's kind of fun to do the impossible. We have been at the sort of the leading edge, the tip of the spear in proving that this stuff works, and then being able to expand it out, right? The event in Dubai where folks pledged over $700 million to continue this work is really an outgrowth of the decades that the Carter Center has spent demonstrating that it's possible. And I think when you look at something like Syria, and you see that we have moments here, the Carter Center, again, has been for decades working in what was, for a long time, an impossible situation. And the fact that those relationships exist, the fact that we have the ability to bring forward a lot of ideas and credibility and bring that to bear, I think that really demonstrates what we want to do. My grandparents used to always say that they wanted to fill vacuums. One of the principles that the Carter Center uses is we don't duplicate the effective efforts of others. So if someone else is working on a problem and doing a good job, then they don't need the Carter Center. But if there's a very difficult problem at the end of the road in a difficult place, then the Carter Center is willing to step in. And the mental health work that is continuing today, I wanted to make two comments about that. Number one, my grandmother began her mental health advocacy in 1970. And as I've said before, if you can imagine how far we've come in the last 5 years in terms of stigma, in terms of how we treat people with mental illness, in terms of how we understand it as a part of everyone's physical health and well-being, it has really been transformative. And the impact of that on the domestic work in this country has really been an inspiration for all of the remarkable policy change that you've seen over the last several years. And the second thing I wanted to say about that is this was our only domestic program for a very long time. We have focused, as you can see, all across the world, mostly in Africa and the Middle East in a variety of contexts, but we had done the Rosalynn Carter Mental Health Forum and other aspects for domestic work. And we have done lately in our democracy and human rights and conflict resolution programs more work in the United States. And one of the ways that we've done that is by continuing this bipartisan and cross-partisan understanding that we as the Carter Center can't walk into American politics and not only because we wouldn't do that as a 501c3, but also because it makes sense sometimes to brand things with multiple different people and multiple different messengers to get the work done. And that's one of the things that I think we've done a good job of, both in the mental health program and otherwise, is, sometimes we say this is the Carter Center that's doing this work, and sometimes we say this is Georgians for mental health who are doing the work, or Michiganders for democracy and fair elections, for example. And so we've really been strategic about how we deploy ourselves domestically. The last thing I'll say, and then I'd love to take some questions. I know we're getting close to time here, and it's always good when the actual content takes up my time, since I'm not actual content. Is that as we've expanded, for example, into Chad and Cameroon, in Angola, with respect to river blindness, those are countries where we have long, deep relationships already from our other health work. We're the largest employer in Chad, besides the government, today in our guinea worm eradication program. And so when we can go walk into Chad with a proven method for identifying and eliminating river blindness, lymphatic filariasis, we walk in with a network, a set of connections, et cetera. And it's just, we can't overstate what it means to have 40 years of work in many of these countries where we've never left, where we have been partners, not folks who come from outside the country and do work, but partners in these communities for all of this time. As my friend Mary Robinson says, it's boots and roots, and we've got all of that in many of these places, and it truly gives us an opportunity to do it. I said the last thing I will say 3 times now. The fourth last thing I'm going to say is just to acknowledge that Dr. Schaub, you all can't see it, but sitting up here, like there was no notes. Like, that was not a teleprompter. That was just her, like, incredibly well organized understanding of these issues. And so, like, well done on that. And the data work that has gone into our conflict resolution program, we often talk about how well data-driven our health programs are, and they are. We almost always can show you with great specificity the success and the data that proves what we're doing with respect to our health programs. And many people on the democracy and peace-building sides it's a complicated thing to describe and explain the successes. But one of the things that she has really led the charge on is using advanced data metrics and other things to drive conflict resolution and to drive peace building. And I just think that's remarkable and really bodes well for the future. So I'd be happy to take a couple questions, but only a couple because we're right up against the time, and there's microphones on either side, and they can be for me, they can be for members of the panel, but we'll take a couple. Let's start with Kashi Siegel, if that's okay.
Sure. Good morning. Given the news yesterday of Israel and Iran, I feel like I have to ask, how does that impact our work and the work in the region?
So, letting the expert speak in 1 second, this is one of those areas where the Carter Center has stayed in the West Bank, has stayed in Israel, has stayed in the midst of what is an apparently impossible situation. I first went, my bizarre upbringing means that I went to Gaza City for the first time in 1995. And my grandfather sent me to be a part of an election observation mission. And over that 30 years, we've seen an absolute destruction of any sort of possibilities for peace in this moment. But we've been there for a long time. We're going to stay there for a long time. And I would love to hear Dr. Schaub talk briefly about that.
Thank you so much. Thank you so much for that question. And the conflict is not new. It's just that symptoms reappear in different and more violent ways. And so to Jason's point that we've stayed the course and will stay the course, there are, if you will, the intrinsic or the real drivers of the conflict, and those are the issues that the Carter Center is trying to address. And like I said at the beginning, we work there day in, day out on these tectonic shifting plates. So what are those unchanging truths that we can continue to elevate in this space? And there are many. The Carter Center has called for an immediate ceasefire, for example, when it comes to the war in Israel and Gaza, supporting local civil society and human rights organizations which are the key local voices and voices of peace and agents of peace on the ground, are real actors and allies of the Carter Center. And also the Carter Center works regionally to elevate those voices and also to advocate for peace and security for Israelis and Palestinians, but also to advance Palestinian self-determination. And so your question is very well placed in the sense that every day our work is changing. We have staff that we have to look out for in terms of their security, but again, it's those unchanging principles and the Carter Center's dedication, I think, that is bringing a real impact in these very dire, and that's why I'm wearing a pink jacket, because, you know, times are sad, and so it's important to see the possible and, you know, the opportunities in the difficult situations.
And one of the ways that I think we can do that the most, but this is true in Syria and in Israel and Palestine, is that there have to be credible members of the community on each side of these conflicts that folks can do business with. There have to be partners for peace, and, you know, obviously we've many sides of this conflict, and certainly Hamas has demonstrated that it's it's impossible on some level within this global moment to have them as a peace partner, right? So we have to help find others that can be peace partners in those contexts, and that's one of the things that we're talking about when we're talking about elevating voices, ensuring that we build a civil society, is that eventually down the road there will be people that can actually sit at a table and talk about how to rebuild, talk about what it is that comes next, et cetera, because without that, that is a true prerequisite for any sort of sustainable peace, as she described in Syria. Thank you, Kashi.
Hi. Can you hear me?
Yes.
All right. I'm Charlotte. I first want to say thank you to the Carter Center for all the work you guys do. My family's from Cameroon, so we've been on the beneficiary end of the work you guys do, especially with global health. But I want to ask a question in relation to Chad. Chad recently just issued a suspension of U.S. visas to traveling to its country. How does the Carter Center plan to work around that to still promote global health, especially in relation to onchoriasis and lymphatic filariasis?
Yeah, you did a great job with the onchocerciasis and lymphatic filariasis. It took me like 15 years to learn all these words. Clark's done it too, and it's just in time for him to, you know, almost be done. So here's what's happening, and the director of our health programs could talk about this more. Obviously, the Carter Center works in a host of places: Sudan, South Sudan, Chad, Syria, and I'm not sure what the list is that the Trump administration has laid sort of a ban on, or what's coming next, right? I mean, we've had to address a variety of issues that have arisen in the first 5 months of this current presidential, 6 months now, this 5 months only of this presidential administration, that have really dramatically changed the landscape for both global public health campaigns and democracy, rights, governance types issues, as AID, for example, which was one of the important actors, was destroyed over the last several months. The Carter Center has been enormously lucky, not lucky, but has been in a very good position based on our history, because our actual funding from the United States government was a very small part of our budget. So we are very strong financially, but a huge number of our partners across the world that work with us, alongside us in combating disease, in working on democracy issues, are in deep, deep trouble. And so we are here helping to convene people that are confronting issues, that are helping to look at what this new landscape looks like in this sector where we've spent the last 40 years, and that we believe is crucially important. And so we're going to play an important role there. The specific question that you asked is about visas. So the president of Chad essentially responded to the Trump administration's ban on incoming Chadians by saying he would not issue visas to any United States citizens. So we have in Chad, just so you know, and correct me if this is wrong, about 2,000 employees. Almost all of them are Chadian, right? So our business and our work is run essentially by local people. That's the Carter Center's model. I will say we did decide to implement a new finance software system, and so we were going to send over somebody from the United States to help implement this new finance system. We don't think we can do that now, right? So we're going to have to use some virtual trainings and things like that. But I mean, it's that type of issue that's going to affect us. Like COVID, for example, one of the great benefits of the Carter Center's work is that the people who run our programs are local people, right? They are Chadian people in the capital. They are Ethiopian doctors and public health professionals in Ethiopia. And so during COVID, for example, we were able to continue almost all of our work because we didn't have to travel in order to do that. This will be an issue. We will have to see what happens. I will also note that we have a very, very, very close relationship with the government of Chad. We have a very close relationship with the president himself. And if there were going to be an exception to this rule that would not allow an American citizen to get a visa, it is highly likely that the Carter Center's staff would be the people who would get those visas to be able to go and do that. So we're confronting it. It is an issue. We've confronted a number of issues over the last 5 months, the tail of which will continue on for a very long time as this sector is dramatically transformed. But I think we're going to be okay in Chad, and I think it's because, again, of those boots and roots that we talked about before. But thank you for the question. We'll take one more from Royce Van.
Thank you, Jason, and thank you to each of the panelists. My question is about the intersection between mental health and infectious diseases. I really appreciated you, Dr. Nolan, bringing up the consequences that many people struggling with lymphatic filariasis, that they experience. And has the Carter Center found ways to take strategies from the mental health program and implement those into your work around infectious diseases? And if so, what has that looked like? And if not, what might that collaboration look like in the future?
Beautiful question. This is one of, I did not plant it. This is one of the ways in which the Carter Center has been truly innovative and has done things that no one else has done. We've done similar things with respects to our peace and health nexus in a place like Mali, which we can talk about next time, but I'll let Greg talk about this, and if Sarah would like to fill in, she can. But it's a great innovative thing that we've done. Go ahead, Greg.
Sure. Thanks, Jason. Thanks for the question. I will say that my father is a psychologist, so I've always had a bit of a soft spot in my heart for the mental health work, and for many years have been in discussion with Dr. Bird and her colleagues on the mental health program about those potential intersections. So we have partnered specifically exploring in Haiti. Was one of our first pilot projects where we were convening individuals called hope groups, which are small groups of about 20 or so individuals, basically peer support groups for those individuals affected by the lifelong consequences of lymphatic filariasis. And those groups are essentially self-run, self-contained, and they can be anything from social entrepreneurship. So in fact, one of the groups in Haiti basically functions as a sewing society. So opportunities and occupations and means of life that individuals can do to support themselves. But layering on top of that, can we provide some basic tools to help address the mental health issues that these individuals suffer? Absolutely, several studies from Nigeria, from Haiti, from elsewhere have shown absolutely very high levels of depressive symptoms among individuals suffering from neglected tropical diseases. And so Haiti was one of our first pilot projects. Obviously, Haiti is one of those difficult places that we can't get to in our present time, but we are in the process for the past year or so of scaling up this approach for our work in Nigeria. And so, it's one of the benefits of the Carter Center being a big tent where we have the infectious disease, we have the mental health, we have the peace programs, and so there are opportunities for these intersections and synergies. So let me stop there, and if Sarah has anything to add.
Yeah, thank you. Well, I will certainly not add anything that Dr. Nolan hasn't already shared, but what I will say, my focus is quite different, being focused on domestic public policy. But the intersection and the interconnectedness between physical and mental health is truly at the core of a lot of our messaging and a lot of our advocacy strategy. When we go to the Capitol and we're talking to legislators, many of them are either current or former providers. We have to build in the importance of physical health as it pertains to mental health and vice versa when we talk about it. And we also bring a lot of folks who, both internal, like within our other health programs, but external partners who are expert in physical health but understand that interconnectedness between physical and mental health. One example is I mentioned earlier, our Georgia Parity Collaborative is a coalition of more than 70 state and national groups, and we like to call them our group of unlikely suspects, because not all of them are necessarily mental health advocates with parity at the core of their mission and priorities, but they are providers, they are doctors, they are insurers who understand the importance of advancing access to mental health coverage and how it ultimately benefits the people that they serve, and contributes to overall physical health, well-being, and the wellness of our communities. So like Dr. Nolan said, we're really fortunate to have such a big tent here where we can tap into our fellow experts in-house, but also we have such wonderful relationships with our global community and can bring them in to truly advance these issues.
Thank you, guys. And we're way over the time. You can ask me the question afterwards. Clark, thank you so much for having me.
Oh, absolutely.
Thank you, guys.
Thanks, Jason, and thank you for the questions. Keep them coming. Again, we've got a whole time for additional coffee. Yeah, we do need to.
I know it. It's short. It's
Okay.
short. It's a short question. It's going to be very short. But if you spend 5 minutes with Rosalynn Carter, after she got talking and bragging about her grandchildren, you heard 2 words: stigma and parity. Now, all of you listen carefully, write it down. Give us the name of a legislator that we should contact.
All right. Thank you so much. So we'll get that name to you and make
No,
sure that
do you have one now you can give to this group? A member of the Georgia legislature for this bill 1013.
Right.
Do you have a name for that one?
Yeah.
Okay, can you?
I think we'll follow up with this afterwards. So
good.
thank you so much.
All right,
You always
that's
bring a lot to these meetings, and you guys bring a lot to these meetings by bringing yourselves here and by walking out of this place and sharing. As you know, I'd like to remind you that the Carter Center asked really only 3 things from the members here. First is to attend meetings like you've done here today, to go forth from this place and tell your friends, your networks, about the great work the Carter Center is doing to wage peace, fight disease, and build hope. And third, consider ways that you and your family and network can help support financially the great work and the programs that you've heard today. These things don't happen by accident, and they're not free, but they are gravely meaningful, and they reduce pain and suffering around the world and bring hope to millions and millions of people. So thank you for being part of that journey. Thank you for being here with us this morning, and we look forward to coffee with you guys afterwards. And thanks all of you online too. Thank you.